Hi, everyone. Good morning, good afternoon, and good evening, and welcome. Thank you so much for joining us today. My name is Maria Cecilia de Dios, and I'm a faculty member with the Johns Hopkins Center for Global Mental Health at the Johns Hopkins Bloomberg School of Public Health. The Center for Global Mental Health works to advance equitable, accessible, and culturally responsive mental health care around the world through research, training, and partnerships. We are especially committed to strengthening community-based approaches and bridging gaps between evidence, practice, and policy. We're delighted to have you with us for our speaker series, Who is a Provider? This series explores a central question in global mental health: who provides care and in what contexts? From clinicians to community members, we aim to highlight the diverse people and approaches shaping mental health support across cultures and systems. Each session brings together practitioners, researchers, and policymakers, as well as community leaders, to spark learning, dialogue, and new ways of thinking about who and how care is delivered globally. Today, we're especially honored to be joined by Rochelle Burgess. Rochelle is professor of global mental health and social justice and director of the UCL Center for Global Non-Communicable Diseases at the Institute for Global Health at UCL. She's a scholar activist committed to transforming the academy into a space for the promotion of a more equitable world. She's the founder and director of UCL's Global Network on Mental Health and Child Marriage, and she's also fellow of the Royal Society for Public Health, fellow of the Young Academy of Europe, member of the ESRC Peer Review College and UK Trauma Council, among other international affiliations and advisory board memberships. She is the inaugural director of the Masters in Science in Global Mental Health at UCL, a new program that centers community and social justice perspectives and approaches to mental health globally. We're very excited to learn from their insights and experiences. So before we begin, just a quick reminders. Please feel free to use the chat for reflections or questions, and we will leave time for Q&A at the end of the session. With that, it's my pleasure to welcome Rochelle.
Thank you, Maria Cecilia. And hello, everyone. It's really lovely to be here. I'm just setting a timer to make sure that I don't ramble on too long and that we leave plenty of time for discussion. I think we said about 25 minutes. Is that right, Maria Cecilia? Okay, good. And I'll just give myself a bit of a fighting chance if we prepare that way. And just to check that you people are able to see my screen. Now I'm sharing slides. Perfect. Okay, well, thank you so much for having me today. I'm really looking forward to talking about, I suppose, community as providers. I'm a community health psychologist by training, and for the entirety of my sort of academic career, I have been committed to understanding how communities can be better included in planning, designing interventions, and leading interventions to improve their mental health and well-being, and sort of advancing the idea that community mental health is much more complex than we give room for. So in the short time that I'm talking today, I'll sort of point to a few themes that have emerged in my work over the years in that space and thinking about, communities as providers and sort of what that means when we really sort of open up towards the totality of what community care could and should look like. So, I think one of the main questions that often occupies my thinking is this idea of how we are able to meaningfully and work to meaningfully respond to what people say they need. So what people's quests for therapy and quests for care are. And in my book, which is called Rethinking Global Health Frameworks of Power, I talk a lot about how in many different health spaces, one of which is mental health, we sort of oftentimes get locked in cycles of hearing without listening. And so in that regard, I'm talking very much about how we sort of pick up what people say, reorient it into different packages to fit with our own knowledge systems, and as a result, sometimes leave people's real desired aims out of the solution. And I think that so what I'd sort of like to do today is sort of unpick how this manifests in the space of mental health and with a particular focus and emphasis on communities. So first off, I'll start with a bit of a background, a rapid fire reflection on different definitions of community and sort of the ways we understand and sometimes misunderstand that complexity of community. And then I'll spend the rest of the talk really talking about the way that we can recenter community as part of people's quests for care and sort of really imagine the ways in which community operates, I suppose, as a primary provider for a lot of the important types of care that contribute to mental health and well-being, but also the really important work of building worlds where good mental health is possible. So what do we mean by community? I mean, community is often a very commonly used term. Um, Typically in public health and health landscapes, we are often emphasizing or focusing on the geographical dimensions of care. And by here, we might be talking about sort of the place-based ideas of community, where people live, where they work, where they engage with sort of structural realities, how I suppose, you think of like borders for accessing care and people transiting and going across borders to get care that might not be available in one place and is only available in another. So this sort of oftentimes can lead us to thinking about sort of these geographical dimensions of care and services and how do people access care. Then you might be thinking about barriers to care, accessing, how do we increase people's ability to access care, but largely around this idea of community of place. But a lot of times there are an underappreciation. So this idea of sort of this misidentification of community about these other types of community that are always circulating within any given community of place. I was in a talk this morning where a colleague sort of really used a very nice metaphor to say, if you came to my sort of village and knocked on my door and my neighbor's door and on each side, you would get very different narratives about what it was like to live in this area, in this village. And I think that that's a really nice example to sort of really get into the ways in which other dimensions of personhood or selfhood or identity, as it is often discussed in social psychology or psychological disciplines, really embody and can shape, people's experience of place. So they might have communities that coalesce around shared characteristics. I think, when Maria Cecilia was discussing the different communities that attend this series of talks, she already identified multiple different sort of groups that have shared characteristics around practices, as one example. But we can often think about sort of an illness identity, so people living with depression or anxiety or schizophrenia, um, or other forms of psychosis, or people living with a mental health condition also composes a different category or identity category that people might coalesce and commune around. And then there are other sort of like social or societal identities that are connected to our locations in the world. Sometimes these can be around in what in the UK we call protected characteristics, so gender, age, ethnicity, religion, race, how we sort of make sense of these different parts of ourselves that connects us to different communities. And as you start to sort of engage with this idea of community, you already start to see how these complexities and these intersectionalities are happening. So people living in a shared geographical area have different experiences of that area depending on their communities of identity, ethnicity, gender, etc., and how those identities are seen in the world around them, valued or excluded. Another key community that I think is a really important one to hold on to is this idea of communities of practice. And so this example of communities who are linked to different practitioner roles, but they often are coalescing around having shared practices, shared goals, or sort of ways to approach challenges, and also shared strategies for change. So they think about driving change and what is needed for change in quite similar ways. Um, And I think that there's often this sort of missing piece where we often forget that actually people can build communities of practice from the ground up, building communities that draw on these other dimensions of communities of identity or communities of place. And so really within that sort of community as a lived entity, when you're starting to imagine how communities form for, organically for the purpose and the necessity of responding to challenges in their worlds, you really start to see that there actually is a lot of power within communities, even though we might necessarily not see them that way, particularly in health spaces where we are working within models that focus on the idea of what communities need, their experiences of marginalization or this narrative of lack. And so you can talk about it as a deficit model and how the need of moving towards more active, positive models of thinking about what community strengths communities have and how they sort of then mobilize those strengths for making improvements in their own lives. And so really the power of community making brings us to lots of other different ways of thinking of community. So in the image here is from a picture from the early breakfast clubs run and established by the Black Panther Party across the United States, these sort of free breakfast clubs, which were then, a model that was expanded on by the US government later on. But I think I like to use the example of the Black Panthers as a really nice example of the positive power of what happens when you're making and building community from a space where there's experiences of marginalization and also imagined narratives of lack. So you see the fact that communities can imagine themselves in different ways and start to build those imaginings towards shared visions of the future. So communities then become a product of these different alliances that they build in order to achieve shared goals. They hold a lot of potential to build responses and systems that are, you know, meaningfully and immediately reactive to the needs in communities. And they're really good at translating vision into action. And I think it's really important to, when we're thinking about how we engage with community as providers in the space of mental health, we remember this positive power of making community, of building community to sort of as part of our process of recentering. And so, what does that actually mean if we try to extend that logic into this idea of care? So, I think there's lots of different ways that we can define care that are expansive beyond the idea of just the sort of medicalized or psychosocial supports that we give for that are needed for responding to a mental health condition. And when we see that most actively is when communities are able to lead the way in defining the boundaries of care, providing the resources and responding to sort of articulations of need that are much more complex and oftentimes pull in those dimensions of community of place that are contributing to the development and the experience of poor mental health. And they do a really good job of doing that. And so, in order to really engage with that, there sort of needs to be a very meaningful, I think, distinction between how we engage with communities. So, typically in public health, we can think about our work as being community based. That really resonates with the idea of communities being located in a geographical place, and we're thinking about distributions and access of care. But sometimes, in line with that sort of community of place, we end up sort of having as I mentioned, that deficit view. And now community-based work does not negate us from working in positive and equitable ways with communities. I think a lot of times you see really good co-production and co-development and participatory work that is community-based, but a lot of times the boundaries of how that work is set is structured by actors who are external to the community. And that has, potential consequences for the nature of fit between what we provide and what people request. So if I speak, will you hear me? Are you hearing the totality of, not just, what this community looks like demographically, but what this community looks like as it is lived, as my mental health is lived. And compared to this, on the sort of perhaps if we use a continuum model at the other end of this continuum, would be community-led work. And the idea around community-led work is it's sort of rooted in the knowledge and the positionality that community actors would always be taking the lead, and us as multiple types of providers, us as sort of actors engaged in the academy and research and provision might be directing our actions in line with what people are telling us, what people are saying, and what they would like to decide. And in the UK at the moment, there is this big shift towards sort of community provision and sort of reimagining what community provision looks like. And one of the big arguments that we're sort of having in that space is, well, what do we actually mean by community, and how much power do communities have in these spaces to determine what care looks like? Is it that we're just placing and devolving resources to the community in a way that is based on assumptions about those communities from the outside? Or is the devolution of power working in a way that communities are able to lead responses on their own and are being resourced to lead and determine their own futures? And oftentimes building the assets or building the opportunities for, mental health enabling environments. And so I think people had access to a paper that was published with colleagues that I sort of work with, and where I actually am today at the Ember program at SHM Foundation. And they do a lot of brilliant work, sort of not scaling, strengthening community-led practice around sort of providing care that comes from people who are leading changes. So we're not really in the process of saying, how do we embed evidence-based practice in these settings, but how do we strengthen Indigenous responses to mental health improvements through marshaling different types of resources and connections? So creating opportunities and a much wider array of solutions for, what it means to improve good mental health. And so we published that commentary in the Lancet earlier this year. And what I'm going to talk about for the rest of the talk are, what does it look like in practice to let the community provide, or think of the community as providers? And so we sort of imagined it in these sort of three different containers, if you will, that cause us to rethink what community is in order to allow communities to provide. So if you want to facilitate community-led transformations of mental health, this is sort of what sort of resonates with, some of the theoretical work I've been doing over many years, the research work that I've done over many years, and I've had the privilege to do with amazing colleagues like Maria Cecilia and our work in Colombia. And what does it actually mean to sort of let and follow communities in their quest to provide their own solutions, and to at times integrate them with systems that would be really powerful for strengthening them. And sort of how these frameworks really resonate with what SHM has seen on the ground with supporting the many organizations they've worked with over the years. So I'll go through these in turn. The first is the idea of thinking of community as an active space where quests for justice are happening. So in that sense, we're thinking about, how do we ensure that communities' desires or quests for care, when they extend into these sort of spaces of the socio and political economy of poor mental health, how do we sort of hold space for that to remain part of our work, right? And so one of the ways we say that needs to happen sort of epistemologically in the space of knowledge is that communities themselves define the boundary for actions. So at no point do we start saying, this does not count as mental health care, that counts as promotion, et cetera, et cetera. We sort of leave these frameworks out of it and say, if this is your holistic vision of care, then this is your holistic vision of care. And so the boundaries are much broader. And then practically, the response to enable that actually to happen in practice requires that we shift our funding so that community organizations are funded directly, and they have flexibility in the funding that they have in order to be much more agile in responding to need. And I think this is really important as we sort of imagine the worlds that we're living in at the moment, these constant interlocking, intersectional polycrises. When grassroots organizations are responding to need, they need that flexibility to be able to really think and respond to the reality of what it means to when mental health is lived which moves me on to the second dimension or domain, which is thinking about community as the space where mental health is lived. And this particular perspective actually enables the first. So they're sort of in this linear imagery today, but actuality, I sort of see them as sort of like a cycle because they sort of really inform each other and enable you to act in diverse ways. In a similar thing, epistemologically, we are prioritizing community knowledge and definitions of mental health and care. So that means like the definition of what is good mental health is always going to be locally defined because your ability to sort of navigate that community of place is the thing that's going to determine whether you have good mental health or bad mental health, not just sort of like your own knowledge system or understanding of symptomology. And so, how do we sort of make space for these pluralistic knowledges of mental health alongside those pluralistic definitions of care? And in order to do that, then we need to sort of be able to embrace this intersectionality of community. And what that means is acknowledging that when we try to do sort of lived experience work, what we're oftentimes talking about is much harder because what are you talking about people having lived experience of? Are you having talking about them having lived experience of the drivers that lead us to have poor mental health, lived experience of what it means to be a Black woman living in London or Boston or Chicago or Washington or Toronto or Bogota, where you are living and what your Blackness means in those spaces is always going to be defined by multiple different things, and multiple perspectives of community, which I tried to lay out when we started before. And then finally, this idea of community as sites for complex action. And so here, really epistemologically, it means that we should be thinking about community contexts and environments as a scaffold or the social scaffold that either enables or disables mental health. And so if you think about community in that way, then it means that lots of different types of action become part and parcel for how we respond to need. And so, really, that sort of makes space for social justice efforts that are addressing structural, political, and other types of violence are seen as part of how we might treat something. So, the provision that an organization is doing to sort of engage with somebody's legal status in a country um, is just as important for their mental health as is providing them access to antidepressants or psychological therapies. And actually seeing those two things as intimately related and equally necessary to each other as part of a mental health package or care is really important. And I think that actually one of the tensions that I often come up against is my work is actually thinking about, well, if you begin to embrace these quite dynamic, complex types of actions, who are the best providers to do that? And I think in some instances it must be communities themselves because communities themselves again are the scaffold. They have that particular knowledge, they have that particular ability to think across multiple domains and working in partnership with communities as providers. And I'm not talking about I think well, I'm not talking about sort of the model of like lay providers. I'm actually talking about something much more broader than that, thinking more about sort of, I suppose, activism. And how do we think about like sort of activism as a way in which communities in all their multiplicities can contribute to care? And I think that's really powerful and gives me a lot of hope, particularly in spaces where um, certain bodies are becoming more marginalized than others and require sort of political engagement as part of how we protect them. And I think that is something that we need to sort of try to grapple with and really hold on to as we sort of expand this sort of vision of care. So I think that this is my last slide and I am magically on time or ahead of time. But I guess I will just wrap up by saying that I think it's important to, if we're thinking about who provides and going to sort of go that extra step with thinking of the community as providers. In order to do that, we have to sort of embrace a much more expanded definition and vision of what counts as care. We need to really resist the way in which knowledge hierarchies might limit us from embracing and including sort of different community understandings of mental health or structural environments or structural experiences as valuable within our work, and an embracing of diversity in that process. And diversity not in the sense of, ethnicities or marginalized identities, but actually diversities in ways of thinking, diversities in types of action, diversities in identities, and all the different ways in which, we, I think, engage in caring work. And I will stop there and open up for questions and reflections. Thank you.
Thank you, Rochelle. That was brilliant. So, give me one second because, all right, yeah. So that was brilliant. I have a broad question for you, and then I'm sure everyone. I'm seeing lots of questions in the box in the chat box, so I will open it up for discussion in a bit. So I'm thinking about what are some of the key implications of this approach for the field of global mental health, and here I'm thinking specifically about both conceptual implications and also practice implications.
Mm.
What does it mean to apply what you're proposing to our day-to-day work and research around the world and locally in the US as well, of course?
Yeah, yeah. So I guess I think what it means for me are a couple of things. So in global mental health work, I think it becomes important to I suppose think about like because I guess global mental health work is very sort of research oriented, right? And maybe I'm coming at it from like a research, and it can be sort of not just research from a conceptual space, but actually, implementation science, etc. Is that how do we challenge or deal with our implicit biases about knowledge? And I think this is it's a really tough one because we're all everywhere, and everywhere people are trained in disciplines, right? And so we have these disciplinary frames and trainings, and they are become the glasses with which we see the world. But in oftentimes, I think, like you would with real glasses, become very attached to your own. And when that sort of attachment is also embedded within sort of, I suppose, inequities across systems, what does it mean to be in a big world-leading university like Johns Hopkins, working in partnership with communities? Those sort of power dynamics set us up to relate in certain ways where even the most well-meaning critical academics can, and I myself have in on many occasions also fall prey to this, thinking that the way you see the world is the way the world is. So how do you, I suppose, and how do we sort of create space for reflexivity of that in a way that forces us to take our glasses off and put on somebody else's glasses in order to make sense of the world? And in that process, use our power to elevate knowledges that are typically excluded, or process approaches that are often overlooked. And sometimes that's disciplinary, so looking at multidisciplinary work, but actually sometimes it's about embedding embodied knowledge about what it means to live through the world and be in the world, and take that seriously within the way that we design and research and the questions we pose and the way that we work, and sort of trying to hold on to that much more within a sort of a in the space of our work. So I would say that's sort of what it makes me think about in terms of what it means for us as global mental health or practitioners working in anywhere in the world, you know, low resource settings and high resource settings where many people have experiences that are almost identical to what we see in low resource settings. And I think then practically, for practice, what does that mean? One of the things I came across recently, or for in my work that I've been thinking about, and then came across recently, is I've been thinking about like sort of how do we make it easy for people to hold on to intersectionality? Because intersectionality is this big word that we use all the time, and it's like, yeah, think about everything, hold everything. Um, but one of the challenges is that that can be quite abstract, even for people who we all hold intersectional identities, and you don't want to use that word. So how do we sort of create sort of frameworks or platforms to help us operate, not operationalize, because it doesn't quite sound right, but like make it a bit more tangible? And one of the things that we've been working with through that is sort of this idea of a socio-political economy of global mental health. And what we did in that framework or paradigm was to actually put in one place sort of all of these different determinants of the social determinants. So thinking about the things that make the world the way it is, the things that lead to the patterning of poor illness, the things that lead to sort of this long history that we have of some groups always being the minoritized, excluded groups. Like, we see these patterns in social determinants, but they come from somewhere. And so what we do in that framework is say, okay, can we make plain and make explicit where these things come from, and then put that in our thinking and put that in our practice? And I came across a framework the other day by sort of radical social worker Dawn Belkin Martinez. I think she's based at is it maybe Boston University? I can't remember, and I might be getting this wrong, so please forgive me. But she and her colleagues write about this sort of just like a justice triangle and using that in their care encounters. And so what that does is it sort of puts the person in the middle of these big structural realities. And it was the idea that that theoretical framework could be used within a clinical setting to talk about some of these big things that sort of create a particular social location or lived experience for someone, and then hold on to that within care by using a framework that is directing us to think about society, think about structures. And we also thought that our framework could also be really good in thinking about implementation science to make sure that actually when we're um, evaluating programs to think about how they work or thinking about things like feasibility, we're actually thinking about, well, how does this program stand up to what things like, classism, racism, coloniality produces in people's lives? Can we be using implementation science frameworks to also assess and explain and engage with that? And so I think that becomes a bit of a way to sort of hold on to some of these ideas around, I suppose disrupting how we provide and how we think about who can be a provider.
Yeah, no, absolutely. And you're making me think of a word that I always kind of like get when one discusses these approaches, participatory approaches, transferring power to community is messiness. Kind of like,
Yes.
what do you do with this? Like it's so complicated and you're trying to tackle these huge structural problems. So what
Yeah.
is it? So I guess a nice way of thinking through this is kind of like splitting it in smaller questions, right? So
Yeah.
I was wondering, how do you respond to this expanded community anchored knowledge of what mental health is, right?
Hmm.
And what are some of the implications, like in terms of which actors are needed? Like, where do policymakers come, to play? Like, what do you do with the solutions that community proposes? Like, or even, who holds responsibility? Like, are communities responsible for sustaining that mental health? How do you
Yeah.
engage? Like, who do you engage? Which actors do you need? And which alliances you need to, like come up
Yeah.
with if you're proposing this approach that is really actually trying to make a change in the world, right?
Yeah.
So I was wondering about that because it's a very common question, and this idea of messiness comes up over and over again.
Yeah. And I think that Um, the messiness is really important to me. I think it's important to make time to sit with the messiness.
Oh, yes.
And so because then you you're able to sort of pick it apart. And I think one of the I guess there's a two ways I want to respond to the question. So the first way I want to respond to it is to pick up on this idea of which actors and alliances. Um, and I think it sort of comes to this idea of, or your question of like, what do you do with people's plans? I think a part of sort of unpacking that messiness is identifying what you can do now that is meaningful and powerful and impactful, and what you cannot do alone. I think it's really important that within community work, and I think community activists and community organizations are always able to sort of say, this is what we can do, and this is what we need more to do.
Mm-hmm.
And actually, these are, and as part of that thinking outward for alliances, what's also really important is thinking outward about your rights.
Mm-hmm.
And so there's also this tension about, some people actually don't have rights, and there's so that, but then that just sort of brings me back to the necessity of pairing justice work of lots of different kinds with how we think about mental health work. Um, and so sometimes if you're thinking outwards, if we use examples from, you know, Agua Bonita and our work in Agua Bonita, that
Mm-hmm.
actually sometimes what young people sort of said and identified as their need for their depression was sort of opportunities to think about university. There was only so much they could do for about that. They needed to extend outward and build alliances. And so if you're spending time and thinking through that complexity, part of that work is identifying the need and then mapping that need to specific actors in sort of these other spheres or domains of society. And sometimes making those connections is easier than others. Sometimes it's a quick connection you can make, but sometimes it's a much longer process that oftentimes requires require different types of mobilization if the
Mm-hmm.
demand you're making is about, you know, access to things that are your right, but you've been denied. And I think that then connecting to sort of activist movements becomes really important because that is such long-term work that requires sort of care and patience and opportunity. And so having that work happen alongside lots of other different types of work, so getting you more immediate access to maybe a mainstream therapy. But if you've got this other long-term work against this big injustice happening, then I feel like for a lot of people, that is also a part of healing. Sort of imagining and being part of a change process against these bigger things that really do matter to our well-being and how we're able to see ourselves. And I guess the second way I wanted to answer this question, it comes back to this idea of community as providers. And I think I've possibly already touched on this, but it's really important that we don't think that community care should always need to fill gaps in the state. I think which
Mm-hmm.
is also something that we learned from our work in Colombia. Like they actually
Mm-hmm.
like our work that we're doing to fill gaps of the state should potentially be temporary work because alongside that, we're starting to mobilize for what people have rights to and don't actually have. It's something that I was pushed on in a talk not long ago about making sure we don't idealize community, and I really that really does resonate with me because community processes around care sometimes are nice and helpful and powerful, but they also sometimes are messy. And also sometimes communities can be sites of care for people. So that's why people often then build alternative or new communities to try and negotiate their needs. So I think, um, yeah, I think for me, uh, it's really about that balance between embracing this activist spirit of what can I do or what are people doing now to respond to this desperate need? What can we do ourselves? And not letting go of the fact that for those of us who live in sort of states where the state is quote unquote functioning, we need to make demands of that state to sort of
Mm-hmm.
like pick up their responsibilities as well.
Great, thank you for that. I'm gonna move on to the Q&A. There are several questions here. I'm gonna try to summarize some of these. I'm already seeing some cross-cutting themes, but let's start by one asking about the tension between epistemic justice and scientific legitimacy. Would
Mm.
you please talk about that tension and that
Yeah,
relationship?
yeah, I saw that question and I thought, oh, that's a good one. Um,
Yes, right, it is.
uh, um, I I think that scientific, and maybe this will win me no friends, but I'll say it anyway, that scientific legitimacy is part of the problem around why we can't achieve epistemic justice. And maybe that's what Vidya is pointing to. So I think ultimately we produce knowledge in closed spaces a lot of times, right? So like we think that we're producing open source knowledge, and there's a value sense around science about, and science is very important, and we have the scientific method which has given us fantastic, beautiful, life-changing things in the world. But also in the process of that, we have moved away from sort of the things that lay knowledge has to teach us because it is not seen as empirical. It is not seen as objective. It is not seen as, you know, legitimate. And I think that, uh, and this is not something that is contained within any one type of method. I think qualitative research or quantitative research, both of them fall prey to
Mhm.
this sort of tension.
Yes, absolutely.
Um, and so for me, I think one of the ways that we sort of try to handle that tension, if I sort of think about how we might need to shift and change and think about what we do with scientific knowledge once it is produced. So if I put it this way, if I talk about sort of the work that we do at PLOS in the PLOS suites of journals, I'm one of the editors of chief of PLOS Mental Health, and one of the things that we did when we were setting this up is that we really wanted to make sure that there was a space for people with lived experience to publish their work that they lead. So not being on grants, not doing research, but like actually thinking about how do you put sort of classical research into a much closer dialogue with lay perspectives, with lay analyses, with essays that are sort of dealing with all sorts of things,
Mhm.
that are also go through also go through peer review. And I think that one of the reasons and one of the things that's powerful about that is that in the same space, which has legitimacy, you have these two different types of knowledge. We're not saying that within a journal you can only have one type of knowledge, which is knowledge that is reified and produced in institutions, academic institutions, or policy spaces or whatever. But actually, you can say this embodied knowledge that you have about your experience can sit alongside these things. They can sit in the same space. And that's sort of how you model or practice a process of legitimizing of knowledge, that you take it as it is, and it should be able to stand next to other types of knowledge as they are. And I think there are other examples out there about how indigenous communities sort of have been creating sort of frameworks and models for how researchers who want to engage with these communities have to act, and who owns knowledge and where it's located. And so I think it's like the San peoples of Southern Africa have a framework about sort of that determines how knowledge can be produced about them. And there's also indigenous communities in Canada who have similar frameworks, and I think there's also one in New Zealand linked to the Maori people. And I think for me, these are also examples about how, like, traditional knowledges and traditional knowledge systems legitimize themselves as standalone entities that
Mhm.
stand on their own in parallel and next to the knowledges that are produced within scientific spaces. So I think for me, that's how we move towards new spaces where we can turn that tension into something productive.
Great. So many questions, so little time. So I'm trying to try to condense some, but Emma asks, so this one is a good one actually. I'm interested in making government governance more local or at least locally responsive. So given these various intersections that bring together community, how do you imagine involving communities in decision making at a policy and legislative level? And this is something we've been thinking about. So
Yeah.
this one is a good one.
Um, so I think that that is a really nice question and um, a really important thing to think about. One of the things that I've been talking about recently in my work are citizens' assemblies. And I was on a talk um, yesterday about sort of climate change, and colleagues were talking about the global citizens' assemblies, which is this mechanism that sort of looks at how community boards or everyday citizens come together to make decisions about planning and legislation or how they feel that challenges should be responded to. And I think international development has lots of models of sort of like what local governance and structures could look like. So there's things around sort of like participatory budgeting. There are things like uh, these sort of health boards that they have they have them in Colombia, they also have them in Brazil, where you sort of have community members sitting in spaces alongside, or sometimes in their own spaces that then feed into wider policy spaces, but sometimes you then have community members embedded into boards. And I think they all sort of have varying levels of success. I mean, I think um, the ones in Brazil are probably the most long-standing. You say that's right, Maria Cecilia. I feel like
Yes.
yeah, I think that, so I think that that is probably the most long-standing, most powerful one that I have heard of.
Mhm.
But they also exist in different parts of Southern Africa, um, and Western Africa, Nigeria. They sort of have community health boards, which sort of work at very local levels and then sort of scale up to state level and nationally. So I think I would suggest sort of looking into some of the international development literature around sort of community, um, I suppose community, I don't know what the word is all of a sudden. I've lost the word. But basically community engagement in sort of legislation and management
Mhm.
and yeah, the word is lost. I think I'm running out of words.
That's fine. We get you. Great. And then another one, so having to do with how would you recommend that one navigates advocacy and community care as a foreigner? Thinking about global work. Yeah.
Yeah. Okay. So I think for me, um, this is rare. This is the second time I'm going to mention my book, and I don't really do that very often. But one of the things that I talk about in the end of my book is the importance of humility as a practice, as an engaged practice, when doing global health work. And so humility in a few ways. One way is epistemic humility. So being humble about what you do not know and being quite open about what you do not know and that you cannot know because you are not from there. And I think that sort of humility will basically endear you to people who you want to work with. Because if you do not know things, then you need other people, right? And I think that that's really important and necessary to do to pick up on that glasses metaphor. You're sort of going into a place where your glasses are completely inappropriate. They cannot work. You don't know anything about the place. So you have to say, look, I'm coming in here blind. My glasses are from somewhere else. Please give me your glasses. Like you teach me. You you teach me. And then in order to practice humility, I sort of talk about um I think I give sort of like 6 or 7 questions to sort of like engage or use within a reflective process about your work and about projects you designed, which sort of attune you to the ways in which power, in ways that we often don't anticipate, um, leads us to work in certain ways. And so some of the questions include things like, you know, what happens if I lead this project? Does my leadership produce anything? Does it reproduce something? Like, does me as a foreigner reproduce a particular type of relationship or remind people of a particular way of working or experience? Um, could somebody else lead this project? What would happen if somebody else led it and I was in the background? Like, so it's sort of this important way of sort of trying to place yourself as part of your work, and using humility within that. And then that means that your community care and your advocacy work will be much more aligned to the local reality of that community of place in this moment of time. I think that's the best any of us can do. And I think humility is important because global health is a field and global mental health is a field that is basically built on the legacy of engagement in the lives of others. And that is our legacy, and that is what we carry. And if you want to get around that, you have to be working to displace yourself, even if you're being placed there for good reasons. And I think that humility is the most actionable way to do that.
Humility as a key practice. The last question is about particularly marginalized populations, or when you're dealing with stigma against certain groups, like people with psychosis, for example. How have you brought communities together with with different perspectives and views?
Um, so I think that's a really good question from a powerhouse like Judy. So hi, Judy. Um, uh, so in some of the work that I've done in Southwest London, actually, around co-production, one of the most important lessons I took away in that work, where I got to be an anthropologist for a while, which was very nice, and I got to do ethnography of co-production, was that actually community building work often means that for the most marginalized person groups, you have to make it a safe space first. So there was a real concerted effort for the people who are most marginalized in sort of the mental health space. So people like sort of living with psychosis, people who had been harmed by the mental health system, that they were actually protected in the early stages of that co-production work. And so they had allies and like sort of these intermediaries that would take their stories into spaces where the power differential was much too big or much too broad. And they didn't think that people would be safe, and that they didn't force people to do that. And so they were able to do this, and over time, sort of move people with lived experience and people with the most stigmatized mental health identities into that sort of like community, sort of dynamic community space. It was like community mental health boards. And they sort of brought them in sort of over time once they sort of, I suppose, these intermediaries took the initial hits. And sort of over time, they were able to build a much safer space for meaningful community and co-production work to happen by sort of having these intermediaries. And so people with lived experience of psychosis and, harm were still working collectively in their own spaces, but the integration of those spaces with these people who used to be opposed, they spent a very long time doing it. And it wasn't until there was the feeling that the people understood these histories of racism and were understanding of the system and the violence of the system and what it had done to people, once they sort of were aware of that, much more aware of that, that was what prepared them to sort of engage in a way that was safer for people with, the most marginalized. And I think another thing that we really learned, and we talked about this, the paper's called Phase Zero, sort of building sort of it's around co-production or around mental health co-production. And the another thing that was really important was that there were leaders, from coming from the NHS system or the mental health system that went into community spaces. So one of the ways in which they brought these communities together was also thinking about how certain places held legacies and power, and to disrupt that, sort of change the location of where people would meet. So rather than saying people from the community need to go into the hospital or go into the university, the people from the universities and the hospital went out into the community and met on community terms in community locations, sort of removed from their centers of power. Um, and then at the time they were also led by somebody who was a real believer in epistemic humility and modeled that for staff. So those things sort of really facilitated, bringing people together with different views. But I think this lens and interest in safety was a really, really important one. And I just wanted to say, Eleanor asked about where the reflective questions were. They're in the end of the last chapter of my book, Rethinking Global Health Frameworks of Power, which is free. You don't have to buy it, so it's not a real plug. It's free online. You could just go Google it.
And it's a fantastic book. So great. I think that wraps it up. Thank you so much, Rochelle, for sharing your work with us today. It was incredibly thought-provoking, as usual, as always. Very thankful for your contribution to the series. So,
Yeah.
also thank you all for joining and engaging in this conversation. So, we hope you will join us for our next session of Who's the Provider. So, this is going to take place on September 9th. Please make a note. We're stopping for the summer. Have a great summer, everyone. On that day, we will be joined by Professor Laura Schild-Seaman and Professor Felix Borlonsky from Timbus University at Utrecht University. So thank you again for being part of this growing community, and we look forward to continuing the conversation. Have a great rest of your day, everyone. Bye
Thanks,
now.
guys. Bye.